So you can see a little bit about how at least one physician felt about the patient dumping problem. And it was a significant issue for underinsured, uninsured, or indigent patients in our healthcare delivery system. So that gave way to a statute called the Emergency Medical Treatment and Active Labor Act, fondly known across the hospital systems all across the United States as EMTALA. EMTALA is federal legislation that was enacted specifically to prevent dumping of indigent and uninsured patients and to ensure that all patients had access to emergency care. It's the single most important law governing access to emergency care that we've ever had in our country. It's a sweeping law. It applies to all hospitals that participate in Medicare. And generally that is like almost all hospitals, particularly acute care hospitals and hospitals that have a dedicated emergency department. And dedicated emergency department can mean many things. I can't recall if I have a slide on that or not. Let me see. No, but a dedicated emergency department is really anytime a hospital holds themselves out as having an emergency department. They have a sign out that says emergency. They advertise that we provide emergency care, or they're licensed by the state as having an emergency department. And almost all acute care hospitals have an emergency department. Now, some hospitals have different levels of emergency department, and that's dependent on many things. In Texas, it's their trauma designation, meaning a level 1 trauma center is the highest level of trauma center, and they will take patients from our EMS system that are, like straight from the scene that need emergency care, trauma care, and then it goes down level 2, level 3, level 4, with level 4 being the lowest level of trauma. They may not have a trauma surgeon on their medical staff, may not be able to provide much trauma care at all. So level 1 being the highest, level 4 being the lowest. So when is EMTALA triggered? EMTALA is triggered anytime an individual presents to the hospital's emergency department or is on hospital property and requests care, or care is requested on the patient's behalf. So if a patient shows up in an ambulance and they're comatose, well, the ambulance drivers are essentially asking for care on the patient's behalf. Or if it's a minor who can't consent for all their own care, if a parent brings them to the emergency department, the parent requests care, then obviously EMTALA is going to be triggered at that point in time. Or if a reasonable person looking at this patient would believe that the individual needs emergency care. And when we talk about when does a hospital present to an emergency department, that's fairly easy because that's where the sign would be, emergency department. There's going to be a waiting room. There's going to be a triage desk. But the law extends to hospital property. So anytime a person's on hospital property seeking emergency care, hospital property includes, under the statute, under EMTALA, the main hospital campus, so the main hospital building, and also parking lots, sidewalks, driveways, any area that's within 250 yards of the main hospital. So a patient can be across the street in the hospital's parking lot, seem to be having an MI or a cardiac arrest or some kind of heart emergency, and EMTALA is triggered, and the hospital needs to take measures to get that person into their emergency department and provide them care under EMTALA. Obviously, they've got to have notice of that, but if somebody came and said, hey, there's somebody across the street, in your parking lot within 250 yards, it looks to me like they're really in trouble. I knocked on their window, couldn't get them to respond, then the hospital would need to send a team over to see if they could provide, bring that person to the emergency department and provide them care. So requirements under EMTALA is once somebody presents seeking emergency care, then the hospital is required to provide a medical screening examination, or an MSE, by qualified medical personnel. We also call those people QMPs. We like to have abbreviations for everything in the medical field. But QMPs generally in a hospital may include individuals who've been trained and deemed competent to provide a medical screening exam. Oftentimes, in addition to physicians, that will be advanced practice nurses and physician assistants. The hospital, depending on their capabilities, may deem other people to be QMPs. So the medical screening exam is to determine if the patient or the person presenting has an emergency medical condition. Emergency medical condition, we've got a slide on that in a second, but to determine that, it's not just an immediate exam. It's not someone going to the triage desk, giving them their presenting symptoms or their chief complaint, and the emergency or the triage nurse saying, yeah, I don't think you have an emergency. It's more than that. It's an exam by the QMP, and it's not just a physical exam. If x-rays are indicated or laboratory tests are indicated or other studies like an MRI or a CAT scan, then those need to be done to determine if an emergency medical condition exists. The requirement then is if there is an emergency medical condition, the hospital, and we're talking about the staff and the personnel in the hospital as well, are required to stabilize the patient or provide an appropriate transfer if the patient cannot be stabilized. And the reason for this transfer and stabilization requirement is that many hospitals, like we talked about, if it's a level 4 trauma center, then they may not have the capabilities to provide the care. If this person needs trauma surgery, needs brain surgery, needs some complex orthopedic surgery, needs various other types of or services, then if it's a smaller hospital, a rural hospital, a community hospital, oftentimes they may not have the capabilities to provide that care. And the only way to get the patient proper care may be to actually transfer that patient. But then there are still certain requirements that we'll see that need to be met. So all of these things, the medical screening examination, determining if an emergency medical condition exists, and stabilizing the patient or providing an appropriate transfer must be done under EMTALA without any delay in treatment, to ask or inquire about payment, to get prior authorization from the insurance company or carrier, or even if the patient is not able to pay at all and is indigent or uninsured, then it does not matter. Care must be provided, and it must be provided without any delay in providing that care and treatment. An emergency medical condition is defined by the statute as a condition that has the patient's presenting with such acute signs and symptoms that if those symptoms and that underlying condition is not treated with fairly immediate medical attention, that the patient's condition would deteriorate, placing the health of the individual or an unborn child, if we've got a pregnant woman, in serious jeopardy. It could impair bodily functions or cause dysfunction of any bodily organ or part. So if any of those things could happen, essentially as if a patient has a condition and it could deteriorate fairly immediately and cause harm to the patient, then the law is going to say that that's an emergency medical condition. Now, this is a medical determination, not a legal determination, but there's been much law based around, does an emergency medical condition exist? And it will be, would other reasonable and prudent healthcare providers or physicians believe that an emergency medical condition existed? And the individuals who enforce EMTALA, which are CMS or the state departments of health, will also look to see, do we think that in any way this patient's condition deteriorated such that it placed the health or well-being of the individual in jeopardy? So EMTALA obligations end only when the patient has had a medical screening examination and has been admitted to the hospital for further care or stabilizing care. And often you're not going to be able to stabilize the patient in the emergency department. They may need to go to surgery. They may need to go for additional procedures in the hospital. They may need to be admitted as an inpatient for, ongoing IV or, IM or any type of medication treatment. They may need all types of treatment that can only be provided as an inpatient. So the only way to stabilize them is really to admit them and to provide treatment over a number of hours or days. Obligations also end when the patient has had a medical screening examination and has appropriately been transferred to another facility. But there are several very strict and stringent requirements for an appropriate transfer. And then finally, when a patient has had a medical screening examination and the determination is that this patient does not have an emergency medical condition. And as you all probably know, many people that do not have primary care providers, they may use the emergency department as their primary provider of care. So people will come to an emergency department with a sore throat, which typically may not be seen as an emergency medical condition. Most of us aren't going to severely deteriorate or die from a sore throat unless it is a severe sore throat. So I'm not saying it can't be, but showing up with a sore throat, possibly an ear infection, a minor cut, those types of things may be deemed to be not an emergency medical condition, but they've still got to have the examination. So generally, once they get the examination, they will have appropriate treatment and then be sent on their way. But if they're, the QMP, the physician or the QMP determines no emergency medical condition exists, then the EMTALA obligations end at that point in time. We'll take up the rest of our class on EMTALA in our next video. Okay, we're back to discuss the remaining requirements under EMTALA and a few other obligations that hospitals have in the hospital-patient relationship. But first, let's continue on with EMTALA. So EMTALA does require, if the patient has an emergency medical condition, and if you will remember, an emergency medical condition is any condition that if it's not treated fairly quickly, the patient's condition will deteriorate and place the patient in some type of serious jeopardy or be detrimental to their well-being. So if the patient has an emergency medical condition, then a patient then needs to be treated, have care provided, until there's no more material deterioration in the medical condition, until it's not likely within reasonable medical probability. And so at that point in time, the patient can be transferred to another facility if that's the appropriate or would be the most appropriate care. Or, as we will talk about in a few slides in the future, there may be managed care restrictions on the patient continuing to receive care after they're stabilized. If a woman is in labor, then stabilization is upon the delivery of the child and the placenta, and after a reasonable time of observation, the physician certifies that the woman is in false labor and not about to deliver the baby. Requirements for an appropriate transfer if the emergency medical condition has not been stabilized. So if it has been stabilized, the patient can be transferred to another facility. The patient may choose that. It may be for insurance reasons or so forth, but that requires stabilization. If the emergency medical condition has not been stabilized, then there are several requirements for transfer. One, the individual can request the transfer in writing after they've been informed of the EMTALA obligations, meaning this hospital where you are right now, we will provide your care and treatment. And you also have to tell them of the risk of transfer. If the patient still says, no, I do not want to be treated in this hospital, I want you to transfer me to XYZ hospital. And so if the hospital where the patient is in the emergency department at the time calls XYZ hospital and they say, yes, we'll take the patient, you still have to have that the patient's requesting it and has been advised of the risk of transfer. And that needs to be in writing and documented, and the patient's going to need to sign a form saying that they are requesting this transfer and they've been informed of the risks of the transfer. The other time is when the physician certifies that the transfer of the patient outweighs the risks of not transferring the patient. So again, if we're in a small rural hospital or small community hospital that maybe doesn't have the capabilities to perform trauma surgery, or to perform, some other emergency need that the patient may have, then the physician may say, we've got to get this patient transferred to a larger hospital, or a hospital that's capable of providing certain care that the patient needs. The physician has to certify that in writing in the medical record. If a physician is not in-house, not in the hospital, and again, some community and rural hospitals will not have physicians available in the hospital 24/7, but they will have a QMP that needs to be available 24/7. So it may be a nurse practitioner or a physician assistant. So if no physician's on site, then the QMP would need to call the physician that's on call for the emergency department, consult with that physician, and determine if the transfer outweighs the risk. Later, when that physician comes into the hospital, they will need to sign that certification. So those are the only times that a patient with an emergency medical condition that's not been stabilized can actually be transferred. And then plus there has to be an appropriate transfer. So what qualifies as or constitutes an appropriate transfer? An appropriate transfer requires the transferring hospital to provide treatment that's within its capabilities to minimize any risk or harm to the patient. So you can do all you can to try to get the patient stabilized. So again, if we've got a trauma patient, maybe they have internal injuries, are going to need surgery, but you don't have a surgeon on staff that can do that, well, you can still give the patient fluids, give the patient medications, do other things that will stabilize the patient before transferring them to the accepting hospital. The receiving or accepting hospital must agree to the transfer, and they have to have the capability and capacity, meaning a bed for the patient and the staff, and both the medical staff and the nursing staff to treat the patient. The transferring hospital must send pertinent medical records, and the transfer must occur with qualified personnel and equipment. And there's been litigation over who's responsible for the transfer. So even though the receiving hospital may say, yes, we can provide the care and treatment that patient needs, until they reach that hospital's doors, the transferring hospital is responsible for the patient's care, because they haven't even showed up to the accepting hospital yet. Now, one caveat to that is if the accepting or the receiving hospital has a transfer team. They may have a ground transfer, ambulance transfer team that's specialized, or they may have flight capabilities to go get the patient in a helicopter or in fixed wing aircraft. I work at a pediatric hospital, and we have a transfer team that's got special capabilities, special training. We have special ambulances, special helicopters, special fixed wing aircraft to take care of the sickest of the sick pediatric patients. So if we send our transfer team, then when the transfer team gets to the hospital where the patient is and assumes care of that patient, puts them in our ambulance or puts them in our helicopter or fixed wing aircraft, then it is now the receiving facility's responsibility, because it's that receiving facility's transfer team that's gone to pick up the patient. Otherwise, the transferring hospital maintains responsibility for that patient's care until they hit the doors of the receiving hospital. If a patient refuses a medical screening examination or necessary stabilizing treatment, the hospital again has certain requirements. They must inform the patient of the risks and the benefits of the medical screening examination and the treatment that the patient would then receive. They must document the exam or treatment that was refused by the patient, document that the patient was informed of the risks of not having an MSE and not having the recommended or required stabilizing treatment, and obtain that refusal in writing. If the patient refuses to sign, then it is recommended that you have at least 2 witnesses sign, other than the physician or the staff that's taking care of the patient. Then you should have 2 other witnesses, if possible, sign that the patient refused, the patient left AMA against medical advice, without the screening exam being done. And that will happen. A patient may sit in the hospital waiting room waiting to have the medical screening exam. Hopefully, if it's, looks to be an emergency, they won't wait long. But some people will leave without being seen. And you still need to document that the patient left and essentially refused the medical screening examination and the stabilizing treatment. EMTALA record-keeping requirements include maintaining all related records, medical records, and other records for 5 years. That's actually pretty minimum. Most state hospital licensing laws are going to require that the records be kept for longer than 5 years anyway. And then for pediatric patients, for example, there may be a requirement to keep those records until the patient is 18 years old, or in some locations, 21 years old. So there's fairly significant record-keeping requirements that are generally above and beyond what EMTALA requires for record-keeping. But in addition to the medical record, EMTALA is going to require any transfer records be kept, any emergency room logs of patients checking in be kept, and those types of records. Any documentation of the patient's refusal, those should go in the medical record, but if they're also kept in other places, all of those records should be kept at least 4 or 5 years. EMTALA requires that hospitals maintain a list of physicians that are on call for stabilizing treatment, and they have to maintain those lists, and then maintain a central log for every patient who presents to the emergency department seeking care. And then that log needs to include what treatment was provided and whether that patient was transferred or discharged from the facility. So when I talk about a log, some facilities probably still do continue to maintain, what we would call a paper log or a logbook, but most of those logs in 2020 are going to be electronic logs and electronic record keeping. And then also the log would need to document the patient's refusal of the MSE or stabilizing treatment, so refusal of care. Reporting requirements. So all of these things that a hospital has to do, it's like, well, how does CMS or how does the state Department of Health monitor this? Well, one is a reporting requirement under EMTALA that a receiving hospital, if a receiving hospital gets a patient and it believes that that patient was transferred from another hospital with an unstable emergency medical condition in violation of EMTALA, the receiving hospital must, and it's a must requirement, it's not a may, that receiving hospital must report the violation to CMS or to the state survey agency, typically will be the Department of Health. And failure to report a transfer of a patient that was unstable and needed stabilization, failure to report that subjects the receiving hospital to termination of its CMS provider agreement. So hospitals take their requirement to report very seriously, but if they report and then CMS investigates or the State Department, the Department of Health investigates and they determine that the transferring hospital violated EMTALA, then they are subject to penalties and liability too. But the reporting requirement it basically can have it'll have implications for both the receiving hospital if they fail to report and the hospital that transferred inappropriately. It's a very serious obligation, and hospitals do not want to lose their CMS provider agreement status. You'll see this from, let's say, again, I work in a pediatric hospital. We have close proximity to an adult hospital. And there's been situations where they call us or we'll call them and say, hey, this patient showed up over here. So the adult hospital may say, hey, this parent showed up with a child, or it doesn't matter. It could be the parent showed up. It could be an adult comes, to our hospital to seek care and then realizes once they've checked in, oh my goodness, I'm at the pediatric hospital. I don't want to be here. And they will leave on their own to go over to the adult hospital, and the adult hospital will call to check on that. Well, if the patient did that on their own and we fully told them, no, we can treat you here. We'll do a medical screening examination. We'll make sure that you are stable. And then if it's appropriate to transfer you, we will do that by calling the adult hospital and transferring you over there or whatever might be needed. But that would be required if we see the patient. So we would see any adult patient. If they left on their own and we didn't tell them to go, that would be a different story. But if in our pediatric hospital, for example, we were to say, oh, you're an adult, you've showed up here, you're asking for care, but really it would be better for you to go across the street and go to the adult hospital because that's probably where you're going to end up anyway. That would be an EMTALA violation. Vice versa, it would be the same thing for the adult hospital to have a pediatric patient show up and say, you'll really be better if you'll go over to the children's hospital. That's where you're probably going to need to be admitted, and they're going to admit you over there. So just go on over there. That's an EMTALA violation. You can't do that. You first got to provide that patient, whether they're appropriate for your hospital's scope of ultimate care or not. You've got to provide them with a medical screening examination, with stabilizing treatment, and then an appropriate transfer. Penalties for violating EMTALA can be quite steep. One, it can mean termination of the facilities or the hospital's CMS provider agreement, meaning that you would no longer be able to get paid for Medicare, Medicaid patients, get federal funding. That is devastating to a hospital. The hospital can also get fined $25,000 to $50,000 for one EMTALA violation. Fines to physicians can also be up to $50,000. And there can be a civil action against the hospital. So a private cause of action by the patient who says they were harmed by the hospital's violation of EMTALA and refusing to, treat them, provide an MSE to determine if they had an emergency condition or not, and then refusing to stabilize them or not stabilizing them. You can have a civil action against the hospital. There is no civil cause of action against the physician. So how do hospitals, sync up the physician's requirement to treat a patient if the patient, wouldn't, one, there's a fine to physician, but if there's no civil cause of action, most hospitals and hospitals are required to maintain on-call list of physicians. And so hospitals will have, for all different services that the hospital might provide, physicians who have to take call. And if they're called while they're on call, then they have to come in and treat the patient or stabilize them, admit them to the hospital or whatever. So that's how the hospital lines up their duties with the physician duties, is requiring the physicians that on their medical staff to take call. And that's what most hospitals will do. There are a lot of managed care implications under EMTALA now because any patient, as we've talked about, shows up seeking emergency care. Then that hospital has to provide that level of emergency care, determine if an emergency exists, and provide stabilizing treatment. But if the patient's in a managed care network, the managed care network may say, oh no, we're not going to pay for that. You've got to get prior authorization first. Well, EMTALA won't let you do that. You've got to provide the care without regard to the patient's ability to pay. So generally what has developed is that managed care providers will go ahead and provide that emergency care that's needed to determine if the patient has an emergency medical condition, and then will also provide for stabilizing treatment. But once that's done and the patient's been stabilized, then that managed care may say, now all bets are off and we're not going to pay you any more for any treatment provided to this patient. This patient has to be transferred to a hospital or to physicians in our network because you're an out-of-network facility, meaning the network or the managed care doesn't have any agreements with that hospital or with those physicians to provide care, and they want that patient to go to a hospital that's in network that they have agreements with and so forth. So it causes some friction because patients, we will get them in, or I say we, because I work at a hospital, I deal with this all the time. But a patient will come in, you will determine if they have an emergency medical condition, provide them stabilizing treatment, the patient will be there, and the patient's like, I need to be admitted, and they're going to want to go like upstairs and be admitted to your hospital right away, like to a bed on the floor or to the ICU or whatever might be required. But if they are stabilized, then there's going to be an obligation to tell the patient, well, we are out of network. So we need to call your network, and they may say that they're only going to pay for your care if you are transferred to a hospital in network. Or if you don't want that, then you're going to be, responsible for either your entire hospital bill or at least all the part that is not, it's all of the out of network payments. So those are conversations to have with the patient only after the patient has been stabilized. And hospitals can get in a lot of trouble by having those conversations with patients before they are stabilized. So those are some managed care implications that we face, and that many hospitals, they're complicated. They can be very complex to work through those. But if the hospital admits a stabilized patient, or sometimes even a non-stabilized patient, up to as an inpatient in their hospital, then you may have the managed care network fighting you on payment, saying, you're out of network. This patient should have been transferred and we're not going to pay you. So it's sort of an ongoing issues to try to get these things right and to make sure that you're working within network requirements so that everybody's getting paid and the system's working as it should. But it requires a lot of complexity, and it requires a lot of training on behalf of hospital administrative and clinical staff to know when to do what and when you can seek authorization versus when you just provide care. So again, always remember you've got to determine if there's an emergency, and then provide needed treatment to stabilize the patient. State laws also, we're finally off of EMTALA, but EMTALA is an important law, and EMTALA has made a world of difference in the emergency or access to emergency care that's available in our healthcare delivery system. But state laws often have emergency services laws as well, and also transfer laws or transfer requirements. Generally, a state's emergency services law is going to be very similar to EMTALA requirements for patients presenting to the emergency department. So if you're talking about a patient being transferred from one hospital's emergency department to another because the first hospital doesn't have the capability or the capacity to take care of the patient, that's going to have, implications under both EMTALA and the state's transfer law. Remember, once a patient's admitted as an inpatient, there's no longer any EMTALA obligations. You can't admit somebody just to subvert your EMTALA obligations, but generally speaking, like once somebody's an inpatient, there will not be any EMTALA obligations that can be triggered. But there may very likely be patient transfer laws that can be triggered. So patient transfer requirements under state law often require patient transfer agreements to be enacted between facilities. So if you're a community or a rural hospital, then the state's going to want you to have transfer agreements with various facilities, maybe adult hospitals, acute care hospitals, pediatric hospitals, specialty hospitals. They want those transfer agreements in place so that there is an organized system for treating patients. There may be time requirements. If the hospital A, where the patient is, needs to be transferred to hospital B, then hospital B, after they're contacted and provided appropriate information, they may have a time requirement to make the decision, yes, we can accept this transfer. Those decisions come after usually there's a doctor to doctor or physician to physician requirement, and there may also be an administrative or administrator to administrator requirement, because one, you have to determine, is there an accepting physician? And then two, you have to determine, does the hospital have the capacity, meaning do we have a bed and the equipment needed to take care of this patient you're wanting to transfer? And then the capability, is this within our scope? Often these transfer requirements turn on, is there a higher level of care, or can the receiving hospital provide a higher level of care? If they can't provide a higher level of care, there's really no reason for the transfer. unless it's a network hospital. So again, there's managed care implications. And transfer laws often that are state law based apply to inpatients and not just to emergency department patients. And then finally, if emergency care is not an issue or it's not a transfer issue, so just elective surgeries, procedures, those types of things, can a hospital deny care? Meaning, can a patient just choose, I want to go to, hospital A because it's brand new, they have really nice hospital rooms and hospital beds and so forth. Well, can the hospital deny them if it's elective, there's no emergency care needed, it's not a higher level of care from hospital B, the patient just wants to be there because they have fancy rooms and it's a brand new hospital. Well, they cannot be discriminatory because remember, they're receiving federal funding, so they can't discriminate for improper reasons. But if it's not that, then generally they can at least make these decisions based on ability to pay. So if it's a purely elective surgery or procedure, then before admitting the patient to that hospital, they generally can say, we need to see your insurance, or we need you to put money up front to pay for the care that we're going to provide. Now, again, only elective, non-emergency care that we're talking about. And then finally, that's also becoming much more complex with managed care because of network requirements. So if it's a hospital that's out of network, then they're going to need to be transparent with that patient saying, you can come into our hospital, but we're going to bill you for anything that your insurance or third-party payer doesn't pay us, and we're not in their network. So you're going to owe this amount of money and those types of considerations. Oh, that's it. So that is, let me take screen share off. That concludes our hospital patient relationship. Again, very different than physician-patient relationship, which is generally voluntary and contractual. But hospitals, essentially, they are going to have a requirement to not discriminate against patients for improper reasons, and particularly when a patient is coming in seeking emergency care at all, then to give them a medical screening exam, determine if an emergency medical condition exists, and if it does, then to provide treatment. So many people will say that EMTALA is a back door through the emergency room into that hospital's care. And it can be misused that way, but it's a very important law to provide access to needed and emergency care. So thank you. We'll have some interesting discussion, I think, on this EMTALA law. And I'll see you for the next class.